Next, I invite Dr. Vardhan Gupta for his talk on premium IOL. Expect the unexpected.
Thank you, Dr. Soma. This was like the trick question. This was a sort of trick topic. I did not know what to expect from this talk, so tried to have made something out of it. So, what are the things that we can have which are with the premium IOLs where we can land up in trouble? So, premium IOLs are premium lifestyle lenses. They correct a wider range of refractive errors than standard IOLs, correct presbyopia, then potentially eliminate or reduce the need for glasses at all distances. Multifocal IOLs have different zones for clear vision at different distances. Accommodative IOLs mimic eye's natural focusing ability, and toric IOLs, of course, correct astigmatism. The special considerations are that they are more expensive, not always covered by insurance, and we have to tailor individual needs with specific models. Thorough counseling of patients is needed. The surgical issues are intraoperative, like PC rent and iris defects, and postoperative are residual refractive error, IOL decentration, corneal edema, dysphotopsias, CME, and early PCO. In the back placement, if in the back placement is not possible because of PC rent and if capsular integrity is compromised, instead we can do a primary or reverse optic capture. Iris defects may present as trial illumination defects, iris atrophy and or pigmented dispersion. If large, pupilloplasty to avoid glare and dysphotopsia. And to prevent it, we have, of course, to do adequate pre-op planning, intracameral adrenaline for small pupil and long intracorneal incisions beyond the iris root and low fluidics. Refractive surprises occur in 12 to 15% of the cases because of long or short axial length, previous refractive surgery, irregular astigmatism, keratoconus, corneal scarring or dystrophy, mature cataracts, OSD, and long-term contactless wearers. Also because of anisometropia, dominant switch, post-op high astigmatism, and of course, unmet expectations. Glares and halos, especially with multifocal EDOF lenses, are the most difficult to tackle from the patient satisfaction point of view, and there are other night vision problems also. If there is inherent zonal weakness or traumatic and others because of improper implantation, then we can prevent it with capsular tension ring. And there may be elevated IOP because of retained viscoelastic, which is most common on PO day 1. Patient may be steroid responder, which comes with high IOP 3 to 4 weeks after surgery or inflammation. Anti-glaucoma drugs are sufficient in most cases on a temporary basis, but of course we can have a case of malignant glaucoma where surgery or atropine may be required as the case may be, as the case responds. Iris defect with pigment, IOL redialing, IOL haptic on sulcus, a peripheral iridectomy. CME patients with diabetes and macular pathology are at higher risk. If they do not resolve within 8 weeks, a subtenon intravitreal Kenacort or Ozurdex may give us relief. Of course, to prevent it, pre and post-op NSAIDs, they definitely decrease the incidence of post-op CME. PCO ND yak laser cap is safe. A low energy small yak capsulotomy sometimes is also useful for positive dysphotopsias. So to manage expectations and unexpected outcomes, pre-operative counseling, realistic expectations, good post-op care, promptly address the visual issues, and I will exchange if required, patient education, and still the refractive surprise enhancement by a laser procedure can be done, and which we have done also on occasions. Thank you so much for your kind attention.